Perfect. Great. So you can see the participants are building up. So
I don't get to see them.
no, oh,
That's
so
okay. That's all right.
yeah,
Where are you two based at the moment?
Lisa, yeah.
I'm in a place called Kingston, Ontario, which is about 2 hours east of Toronto.
Yeah.
And I'm currently, oh, sorry, Martin,
Well,
go ahead.
I spent a year in Toronto.
That's the kids.
It's a kid, so I kind of know a little bit of, at least I know the names, if you see what I mean.
Yeah, and I was in Kids too when I was back in my age. Um, and I'm right now based in Saskatoon, Saskatchewan,
Yeah.
and building up the epilepsy surgical program and the epilepsy and leading the epilepsy the pediatric neurology group actually.
We have a
Great.
link because I completed my peds neuro in kids as well. So as an adult neurologist, we
Yes,
do. So yeah, so it was.
and
We
that's
all have
where
that link.
Lisa and I met,
Yes.
right?
Yeah.
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 All right,
All
I
right.
think
So
yeah. Go ahead, Lisa. I
yeah, we
think
can
we
go
are
ahead
good.
and get started. Good afternoon, everybody, and welcome. My name is Lisa Boise-Lomax, and I am filling in for Dr. Whitney today as she's away at a conference. Welcome to the Clinical Epilepsy Teaching Network. Please feel free to fill out your evaluations at the end so you can get your CME credits. It's my great pleasure to introduce Mr. Martin Tisdale, who's the consultant pediatric neurosurgeon at the Great Ormond Street Hospital. He is the Chief Service of Brain, Sight, and Sound, and he is also an honorary associate professor at the UCL Great Ormond Street Institute of Child Health. So he has kindly come here to speak to us about advances in pediatric neurosurgery. So again, thank you, Mr. Tisdale, for joining us. It's a great pleasure to have you.
Thank you very much for the invite. I'll share my screen.
Yes, that would be great.
Oh, I have to just send a request. You should get a
Okay,
request.
and I will allow it just in case.
You're very kind.
Thank you. Yeah, you're welcome. You're welcome.
We'll try again.
Yeah.
Okay. I hope that you can see that.
Yes, we can
Lovely.
see, we can hear. Perfect.
Great. So thank you very much for the invite. So as introduced, I'm a pediatric neurosurgeon working at Great Ormond Street in London. I'm very proud of my very slight Canadian link in that I was lucky enough to spend a year doing a pediatric neurosurgery fellowship at CETN in Toronto in 2012, which is a little while ago, but I now I remember the time very fondly. So it's always nice to interact with the Canadian teams. I've been asked to talk about advances in pediatric epilepsy surgery, and I thought what I would do today was to talk about epilepsy surgery in the context of epilepsy being a network disorder, and to think about how we can usefully use that model to describe epilepsy and to quantify the abnormalities associated with epilepsy, and then to think about how the network model may influence the way that we treat epilepsy from a surgical perspective. So I have some disclosures which relate essentially to some of the topics that I will discuss today. I'll start with some basic stuff, which most of you will know well, but obviously epilepsy is a very common condition affecting 1% of the population. And very importantly, maybe a third of people with epilepsy do not respond well to medication. And as we know, if medication is not controlling the epilepsy, then the patients are in a situation where they will have generally long-term issues with seizures, and there are many associated comorbidities with epilepsy, in particular risk of injuries, admissions to hospital, and significant associations with cognitive delay, memory problems, and poor quality of life, which affects not only the patients but also their carers. These chronic neurological conditions with need for regular medical input are incredibly expensive. And we estimate in Europe that the cost is almost 14 billion pounds a year. And importantly, the impact on quality of life and the cost to medical services falls very predominantly on the patients who have poor control of their epilepsy. This was a study carried out in Scotland in 2000, which looks at what happens to newly diagnosed patients with epilepsy when they start on medication. And the point of this graph is really to show, again, something that you will all know well, is that if you become drug resistant to one or two medications, then the chances of acquiring seizure control with a third, fourth, or fifth regimen of drugs is extremely low. So you can see that in this cohort of patients, once you're onto your third or fourth anti-epileptic drug regime, your chances of becoming seizure-free are reducing to kind of 10% or less. And although we have many possible therapeutic medications available, in many ways, there's little change in efficacy depending on which one you choose. If we contrast that with epilepsy surgery, then in selected patients, we have highly efficacious treatments with surgery, which may give a much higher chance of seizure freedom. This is a nice study which was carried out in India a few years ago, where they were able to randomize between staying on a waiting list for surgery or having earlier surgery for epilepsy, and showing that over a year, there was a huge difference in seizure freedom rates between the surgical and the medical groups, with, as we would expect, the surgical group attaining seizure freedom in approximately 75% of patients, and in the medical group, that number being single figures. Nothing surprising to any of us who work in this field, but nicely demonstrated. And the principles of epilepsy surgery are in a way quite simple. We are trying to identify the area which we think is responsible for seizures, the so-called epileptogenic zone, the area where if we operate or disconnect, we will be able to stop the seizures. We need to determine what the functional consequences are of the resection, because obviously that's a very important part of patient selection and also patient choice around procedure. And then we need to defunction that region, either by, as I say, removing the lesion or by disconnecting it. So in a way, the model that has underlied epilepsy surgery over many years is quite a simple one. We have an area of the brain which you could describe as being the bad part of the brain, the bit which is causing the problem, and seizures propagate from that area into the rest of the brain. And if we can remove that area, then we can prevent the propagation. One of the changes that I've seen in my practice over the last 5 to 10 years, and really in the international epilepsy community, is that we have started to describe epilepsy more as a network disorder. And if we think about what that means, essentially we're really saying that instead of there being a single area, that we're describing it as a set of kind of interconnected nodes and edges, which may have differing levels of disturbance or dysfunction within them. Clearly, the brain is a hugely complicated network of neurons, and what we're trying to do is to develop a network which best allows us to describe what's going on within the brain in ways that we can measure and interact with. And so, like all models, it's a gross simplification, but by interpreting the brain in this way as a series of nodes and edges, we can make some useful conclusions. In many ways, there are many different models of this network disturbance, which can be of differing degrees. And so this model encompasses many different types of patients, those which may have multifactorial networks, or rather networks that are more distributed within the brain. But it also talks to some of the effect of epilepsy on the normal brain, in that you have abnormal activity that may be more prominent in some areas, but either interictally or indeed ictally through seizure propagation will have an effect on the less abnormal networks of the brain, and that impact can have consequences in terms of the comorbidities. Some of our patients may have networks which are distributed more broadly across space, and some of them may have bilateral networks. And you can see that by describing epilepsy in this way, in some ways it breaks down the dichotomy between a focal epilepsy and a generalized epilepsy. And it may be that we can actually bring all these types of epilepsies into a single model where we are looking at the distribution of abnormality within the brain. We've talked about networks for many years, but I think, again, a recent change is actually that we've started to be able to quantify networks in the brain. And I think this is a really interesting and evolving field, and one in which at the moment we don't really have good consensus over what is the best way to do this, or which modalities of investigation we should use. However, we are getting to a point where we can start to apply some mathematics to this, and that's obviously a very good way to sort of to enhance our understanding and our data and start to draw conclusions. And one of the things that we've been doing in my group is to start to think about what are the best ways to quantify the network abnormalities. And I just thought it was useful to talk about some of the ways that we're doing that. And these have started with looking at volumes of particular parcels within the brain. We are using diffusion MRI to understand the structural connectome, i.e. the physical white matter connections between different parcels in the brain. We're using resting state fMRI to look from a more functional perspective and to look at how function and structure might be combined. We can obviously build networks from both scalp and invasive EEG. And then the last one, which I'll talk about a little bit, is the use of single pulse electrical stimulation, again, as a method of interrogating the network and deriving conclusions from it. So I thought I'd just give a few examples of some of the work that we've done. A lot of these techniques are related to comparing both patients with epilepsy to normal controls. A lot of them involve parcellation of the brain, so using atlases to divide the brain into structures, and then applying whichever techniques you feel you want to use to those parcels, building structural connectivity matrices to compare the connections between various nodes, and then analyzing them. One of the complexities that we have in children is that we're often dealing with children across different ages, and so there may be different network changes which occur at different ages, and therefore we apply Z-scoring or other statistical techniques to manage that process. This has led us into the field of network metrics, and outside medicine, and now increasingly within medicine, there are a number of graph network metrics which can be used to describe the networks. This was a piece of work done by one of my PhD students at the time, but now postdoc, called Ashwin Chari, who looked at patients who had undergone resective surgery, therefore patients who were presumed to have focal epilepsy, and compared them to both healthy controls and to patients who were thought to have a more diffuse epileptic disorder and had had vagal nerve stimulation. And what we were able to show is that when we look at whole brain connectivity, there are metrics which are able to determine or define the differences between these groups. And particularly on the right hand side, you can see this measure called mean modal controllability, which describes how easily the brain can be moved to unusual states. And this was able to distinguish between these three categories of healthy controls, a more focal epilepsy and a more generalized epilepsy. We were also able to show that the areas that are resected in patients with focal epilepsy specifically have different network connectivity when compared to the parts of the brain which are not being resected. And again, modal controllability was able to differentiate between the resected parcels of the brain in patients that had become seizure-free versus those that had not become seizure-free. So this gives us some indication that there are specific differences in the network disturbance that we might see in patients who had successful surgery to remove the epileptogenic zone, and that we might be able to use some of these network measures to define areas of the brain which are more likely to lead to seizure freedom if they are resected. The thalamus has become increasingly an area of interest over the last few years, and I'm going to talk a bit later on about therapy related to the thalamus. But at this stage, I just wanted to mention this as a volumetric assessment, and again, a similar technique that we can use parcellation techniques to measure volume of various parcels of the brain and to understand in different types of epilepsy which parts of, for example, the thalamus appear to be more affected. I think it's really important to say that all of these techniques are making assumptions about one measure versus a connectedness within the network, and therefore there is a long way to go to understand where those assumptions are correct and where there's more work. But we were able to particularly show that in areas of the central median nucleus of the thalamus, which is one of the areas that often is talked about with therapy, we're able to distinguish between different types of patients with epilepsy in this study. And that's led us on to thinking about other ways to interrogate the thalamus. This is a study whereby we are systematically collecting stereo EEG data from the thalami of patients who are undergoing routine stereo EEG implantations. Many of you will know that thalamic stereo EEG has become a technique which is being discussed quite widely, and as we'll come on to talk about, it relates then to how we can use that data to think about neuromodulation therapies. This is a study that we've opened only a few months ago, where we're trying to systematically record from 3 areas which are well-known targets for neuromodulation, or to differing degrees. So we're recording from the central median nucleus, the anterior nucleus of the thalamus, and the pulvinar in different types of patients with epilepsy, and trying to make correlations between the location of the epileptogenic zone or ictal onset zone and the changes that are seen in the thalamus. And our hope is that this data will in future allow us to choose neuromodulatory targets in an effective manner. And I think we need to be upfront and say that at this stage, that leap, as it were, from understanding electrical signals within the brain to understanding what the effects of neuromodulatory therapy might be, is not at all completed, and there is more work to do in that area. So I wanted to then just go on and talk about techniques for treating the epileptogenic zone, and how we might be able to use some of this network analysis to think about the way that we provide therapy. The first one I wanted to start off is in a way quite a basic or traditional technique, and in some ways I've slightly shoehorned this onto this talk, but I thought it was useful to think about some of the minimally invasive techniques that we are using to provide a focal treatment really to an area that we think is a key node in the network, which is essentially the seizure onset zone. The techniques that we are using for minimally invasive neurosurgery in these patients are shown there, and really are radiofrequency thermocoagulation, laser interstitial thermal therapy, which has been a real growth area over the last 5 or 10 years, and then the even less invasive techniques of stereotactic radiosurgery or focused ultrasound, which are much less established. When we come to talk about minimally invasive surgery in the context of epilepsy, we really need to think about why minimally invasive surgery has been attractive and what we're achieving with that. There's some hands raised, but I don't know if those are questions we should take as we go along.
I think we have done all the question at the end,
Okay.
Dr. Tisdale. I asked the attendee, and so she will put the question in the chat. Thank you.
No, that's great. I only asked because I suddenly see a couple of hands popping.
Yeah, me too. But thank you.
That's great.
Sorry about that.
So I think minimally invasive surgery as a concept, it's really important to remember that this predominantly came from the general surgical world, and related specifically in the early stages to laparoscopic techniques, whereby it was possible to dramatically increase recovery by making small incisions in the abdominal wall. Now, when we come to talk about neurosurgical procedures and the risks and benefits of neurosurgical procedures, it may not be so clear that minimally invasive surgery and smaller incisions leads to better outcomes. However, there has been a significant growth of this, which is partly led in some cases by patient choice, but also partly driven by the ability to get to difficult to reach areas of the brain with minimal approach morbidity. If we look at the various techniques that are available, you can see that there are pros and cons between them, often relating to, for example, the non-invasiveness of stereotactic radiosurgery or focused ultrasound. Some of the techniques, stereotactic radiosurgery, on the other hand, have quite a delayed action time period, which is certainly of consideration when you're treating children. But as I say, that the two techniques which we've used predominantly have been radiofrequency thermocoagulation and laser thermal therapy. And I thought it would be nice to show a couple of Canadian papers in this talk. We're now beginning to be able to compare across various data sets that have been collected to look at these. And this is a data set relating to outcomes of hypothalamic hamartoma surgery using traditional open surgery or some of the more recent minimally invasive techniques, and really showing the key advantage of these techniques, which is reduction in complication rates relating to the approach. For those of you who have not seen laser interstitial thermal therapy, which has become the predominant technique for treating hypothalamic hamartomas, this is a technique whereby a fiber optic catheter is placed into the brain through normally a neuronavigation guided bolt. And the real key to this technique is that it allows a semi-real-time thermography, whereby in the MRI scanner, one is able to deliver the therapy, but also monitor the temperature of the probe in the brain. And what this allows is for an indication of the size of the lesion that is being produced. So you can see in this slide, there is thermography in the middle, which gives you real-time temperature as indicated by a heat map. And on the right-hand side, the software is able to build up a model of the irreversible damage that is appearing in the lesion, and to superimpose that on an MRI scan in real time, thereby allowing you to build or to grow a lesion using this technique, but also very importantly to protect surrounding structures and to therefore turn off the lesioning before causing damage to any of the healthy brain. And this is what the technique looks like. You can see there a laser catheter which has been placed into a hypothalamic hamartoma. On the left-hand side, you see the real-time thermography, and on the right-hand side, you see the model of the irreversible damage, which obviously, rather than coming and going in the way the thermography does, is constantly additive. The bottom left shows you temperature at various markers in the brain, and that's what would be used to either automatically or manually switch off the laser when the surrounding structures heat to a sort of a point at which one might think the damage might occur. And at Great Ormond Street, we've been working with this technique for now probably the last 5 or 6 years. And we've developed an experience in hypothalamic hamartoma, which has been probably the primary indication for this modality of treatment, certainly in children. This is just a snapshot of our series of hypothalamic hamartoma patients to date, and we've treated 32 patients with 39 procedures who have made it, or rather have over a time period that we've been able to collect 1-year outcome data. Mean age of these patients was 7 years, and interesting that we are able to now treat very young children with this technique using modified neuronavigation techniques, and we've treated 2 patients under the age of 1 year, with the youngest being 6 months. We still have a long gap between mean age of epilepsy onset to treatment, which it remains an issue with epilepsy surgery in general. Many of you will obviously know that patients with hypothalamic hamartoma will characteristically have gelastic seizures. However, only a third of our patients had gelastic only seizures, and it's very common to have other seizure types as well as generalized seizures in this cohort. A number of these patients have had previous open surgery before coming to our institution, and so certainly laser surgery is a technique which can actually quite simply be applied to patients who have had previous surgery, because it is not complex to navigate previous scarring. And these are our outcomes, and overall we've achieved Engel class 1 and 2 at 1 year in about 2/3 of these patients. It's interesting to note that outcomes are better in patients who have gelastic only seizures, whereas seizure freedom rates, you can see their top right, Engel class 1 outcomes in those that have gelastic and non-gelastic seizures is quite a bit lower, and really talks most probably to a more diffuse seizure network, which is harder to treat with a focal technique. The key thing with this therapy is that adverse events appear to be much lower than the previous open surgical approaches. And so in our cohort, we've had no infections or bleeds and no return to theatre, no hemiplegia or visual disturbance. One of the issues with the technique is ensuring no damage to the mammillary bodies, and you can have bilateral heating of the mammillary bodies, which can lead to memory disturbance. And we've seen that in 4 patients who have developed some short-term memory loss, all of which has improved, but has not completely improved back to baseline at an interval of 1 year. Preoperative endocrinopathy is quite prevalent in this patient group, and from those cohort of 32 patients, almost half of them had some degree of preoperative endocrinopathy, and you can see there that a large proportion of that is precocious puberty, but it may affect other parts of the hypothalamic pituitary axis as well. We've seen that the amount of transient post-operative endocrinopathy can occur, and in our series it actually occurred in just over 1/3 of patients, but quite a lot of this relates to the steroid treatment that we use around the time of treatment, shown there by transient adrenal insufficiency and some sodium abnormalities. But it's actually very uncommon to have long-term endocrinopathy. And we, in this series, had 4 patients who ended up with a degree of central hypothyroidism requiring thyroxine replacement. But importantly, no incidence of diabetes insipidus or need for treatment to manage salt and water disturbance in the longer term. One thing we have noticed is that appetite and weight abnormalities are prevalent preoperatively, but also postoperatively, and that increased appetite postoperatively in the short term occurs quite commonly in up to 50%, and again may be related to some degree to the high steroid usage around the time of surgery. A large proportion of that will resolve by 6 months, and by 12 months almost 55 to 60% had resolved. However, it is the one complication we are seeing of hypothalamic laser surgery is that there is a small but important cohort of patients who will have longer term weight gain after this treatment, and it's something that is not discussed that much in the literature. So I think it's really important to get that message out there in terms of patient expectations and preoperative counselling, as it can be something that is quite difficult to manage. If we start to think about how we can treat the network in a more broad manner, I was going to briefly talk about thermocoagulation, which is a technique which we can utilize down stereo EEG electrodes, which are already in place. And this is a technique for obviously passing current between contacts of existing stereo EEG electrodes. And you can see the types of lesions on the right-hand side, which are produced when you test stereo EEG electrodes in this way outside the body in egg white. This is obviously has some advantages in that you are able to produce some network disruption at multiple sites. And so this may be a technique which in certain situations is useful to treat a more diffuse network. And it also can be, because you're responding to stereo EEG recordings, it's in a way a treatment which is directed to the areas where you're recording abnormalities. We wrote up our experience of this a few years ago in partnership with colleagues at Rothschild Hospital in Paris. And you can see that there are, the proportion of patients who become seizure-free with this technique is relatively low, but the transient seizure improvement is more significant. And if you look down the left-hand side of that graph, you see of patients who were recommended for resective surgery and had radiofrequency carried out prior to that. Over a third of them were transiently seizure-free, and a lesser number showed some improvement. But the number that become seizure-free over the longer term is much less than that. We were able to show that it has some utility in patients where resective surgery is not possible. And again, that we were showing about a third of patients who were able to become transiently seizure-free or improved when the network appeared too broad for us to offer resective surgery. This technique also has efficacy in prognosis, and we've been able to show that a transient improvement over a period of 3 months is actually a strong predictor of patients who will benefit from resective surgery and will have long-term seizure freedom after resective surgery. And so it can be used in addition to this therapeutic benefit in a kind of prognostic way to help guide decision making. If we keep zooming out, we can start to think about how we can influence the network on a broader scale. And there are 2 techniques which are have been designed for kind of interacting with the network on a level which is for treating focal epilepsy, but really trying to interact with the epileptogenic zone. At the top, I'm describing an extracortical stimulation. This is a technique which is available in Europe called Easy for You, whereby an extracranial stimulator is placed under the scalp, but over the area of the ictal onset zone. And then in the lower picture, you can see RNS, NeuroPace, which is a technique which is actually more available in North America and I believe now available to a certain degree in Canada, currently not licensed in Europe or the UK. And so we have no experience of it, but certainly is gathering a lot of interest, particularly in the US. And this is a technique where neuromodulatory therapy is being delivered into the epileptogenic zone directly and is being responding to strip electrodes placed over the brain, which are able to detect changes and using that to guide when stimulation is delivered. What I find interesting about these techniques is that they are different methods of interacting with the network, but actually the outcomes of these 2 treatments and of other neuromodulatory therapies, which we will look at, are actually very similar. On the left-hand side, you can see data from the initial RNS study, looking at patients with focal epilepsy and showing essentially a 50% reduction in seizures for 50% of patients over a reasonably time period of 1 to 2 years. And you can see that, as with characteristically we see with neuromodulatory therapies, the response rate seems to improve slowly over time. On the right, you can see data from study looking at the extracranial, non or less invasive cortical stimulation techniques, which actually shows very similar efficacy. So approximately 50% seizure reduction from baseline over the first 6 months, and again, an increasing efficacy over time. And it's really interesting to think about why these different techniques actually seem to have similar therapeutic efficacy, and whether that's because we don't yet, there's more to understand, there's more around patient selection and maybe treatment paradigms, or whether in fact the type of neuromodulatory treatments that we're using may be less important than we think in terms of which one we choose. Zooming out again, we can think about modifying the network on a more brain-wide or global perspective, and this really talks to vagal nerve stimulation, a way of affecting thalamocortical connectivity by using vagal afferents, or on the left-hand side, thalamic DBS, which is another technique which is really garnering interest in the last few years, and one that we're very interested in. To talk a bit more about deep brain stimulation for epilepsy, the rationale for this is based on a small number of studies which have shown efficacy. So this is the Sante study, study of focal epilepsy in adults with deep brain stimulation delivered to the anterior nucleus of the thalamus. This study has not yet allowed us to deliver this treatment outside research settings in the UK, although it is obviously available in other parts of the world. And you can see the outcomes there on the right-hand side. Interesting to see that there was quite a significant lesion effect in this group of patients, in that both the sham and active arms had a reduction in seizure frequency after the procedure, before stimulation was actually switched on. But after month 4, there was a significant difference between the active and control arms, and that change has been backed up with longer term outcome data. The nucleus which we've been most interested in children recently is the centromedian nucleus of the centromedian nucleus of the thalamus, and this study is actually an adult study carried out in Australia a few years ago, where 20 adults with Lennox-Gastaut syndrome underwent deep brain stimulation implantation into the centromedian of the nucleus, with there being initial randomization to either stim on or stim off, and then an open label 3-month stimulation with everyone having obviously stimulation on. This study showed a change in seizure frequency electrographically based on EEG findings, which is in the lower graph there, but did actually not show a significant change in clinical seizures as recorded by seizure diary. And this 3-month period is possibly on the slightly shorter side, which may be why clinical seizure reduction was not shown, and also talks to maybe the difficulties of how we collect seizure data in these studies, with everyone realizing that seizure diaries are quite a flawed method in one way, but obviously EEG also has its difficulties because it captures only a much shorter period of time. So we're very interested in this technique in children, and we published a few years ago a literature review based on deep brain stimulation for children, and essentially quite a lot of this data came from Central American studies, but it appears from the data here that children with Lennox-Gastaut who had centromedian nucleus stimulation seemed to have significant reductions in seizures, with actually 3/4 of them being reported as having seizure reductions of between 75 and 100%. So based on that, we decided in London to put together a research study to look at the utility of central median nucleus deep brain stimulation in children with Lennox-Gastaut, but also to think about the optimum way to deliver that therapy. And conventional deep brain stimulation with an implanted device placed in the chest has some disadvantages for children in that as they grow, the wires may become taut, they may break, they may erode through the skin. And at the time of us putting this study together, many deep brain stimulator devices did not have rechargeable batteries, and therefore that requires obviously the changing of batteries through a surgical technique every few years, which, if it's carried out over a lifetime, can be quite a few surgeries. So we set up a research study with a group called Amber Therapeutics, who have designed a cranially mounted deep brain stimulation with a rechargeable battery, and are using that device to explore the response in Lennox-Gastaut children. So this is our proposed translational pathway. We've commenced with a small pilot study to understand whether this non-licensed device is feasible and safe to use in children. And we have funding to go on and carry out a larger efficacy study, which will be in 22 patients. The third part of the translational arc is to think about adaptive deep brain stimulation. So you will know that RNS is an adaptive technique which responds to sensing the brain. The device that we are using has the ability to provide a background baseline stimulation, but then on top of that to respond to thalamic local field potentials, and therefore to potentially identify seizure onset and to respond in a way to try to stop seizures or to reduce their length and severity. This was the first part of that study, which is now completed, which is the pilot study, where we implanted 4 patients and really wanted to look at whether, as I say, this was feasible for parents to recharge the device and whether the technique was safe and the device was safe. And this is a picture from the first patient that we implanted. You can see the cranial IPG in place and the lead DBS pictures showing the electrodes in position in the central median nucleus. And that study, as I say, is completed and should hopefully be being submitted for publication in the next few months. The next part of the study will be a 2-arm trial to look at efficacy, with patients being randomized between stimulation on or stimulation off for a period of 3 months, followed by, again, an open label period, which will allow us to compare eventually seizure frequency and other quality of life measures after 6 months of stimulation. This is the paradigm for the adaptive component of the study. So as I was saying, most deep brain stimulation devices are either intermittent or continuous, but are not responsive to the state of the patient. RNS is able to respond, but doesn't have a baseline. And we are exploring the use of combining those 2 techniques so that you can have a continuous background stimulation, but then an adaptive component on top of it. The device also has the ability to have a variation in stimulation across time of day and also related to patient position. And so this allows you to think about circadian rhythms. We know that epilepsy can sometimes be more prominent either in the day or night in some patients. And we also are aware that the seizure signal, the electrographic signal of the seizure, may be differing between day and night. And so we may need to tune our adaptive capability to time, and that's something that is possible with this device. The adaptive component requires the building of a classifier, so recording data from patients during their seizures and then reducing that statistically to something which can be modeled as a threshold, and then tuning the device to respond to that threshold in such a way that it can act both as a seizure counter but also as a response to that. And so an important part of this study is obviously the testing of those techniques to understand the the ability of the device to correctly respond and to measure metrics such as sensitivity, specificity, precision, recall, etc., etc. We also have a study due to open in the near future to think about similar technique, but in patients who have focal epilepsy. And this wraps back to the thalamic stereo EEG recording, i.e. can we use recordings from the thalamus during stereo EEG to optimize targets for deep brain stimulation? It's interesting to note that across the world, many groups are starting to do this, but we do not yet have consensus as to how best to choose that target. And just for example, because one part of the thalamus is more involved in the seizure, it may not be that that's necessarily the optimal target for subsequent neuromodulation. So we want to try to understand that relationship by interpreting the thalamic signal data and then using that to decide on a target, delivering stimulation to that target, and then understanding the outcome over a period of time. There is some data coming out that we can use imaging data to not only understand which patients may be suitable for neuromodulatory therapy, but also to understand at an individual level what the response might be. So this is a paper looking at cortical atrophy and in the hippocampus and understanding how that relates to RNS response from hippocampal stimulation. And obviously this is in a way what one would like to aim for in the longer term, that you do not require invasive techniques to define optimal targets for neuromodulation, but we can actually start to do that from non-invasive imaging data, which would be far easier to obtain. It may be that multiple neuromodulatory techniques are required in tandem. This is another paper from Canada looking at the response to adding deep brain stimulation onto vagal nerve stimulation therapy in patients who have not responded adequately to VNS, and showing that there is an increased efficacy of that additive DBS treatment over and above continued VNS. What about the effects on the wider network? So as we said at the beginning, there are multiple comorbidities associated with epilepsy, but in particular, we talk about cognitive detriment, the incidence of social and behavioral abnormalities such as autism, and also psychiatric disturbances such as depression, which are highly overrepresented in children with epilepsy. It's really interesting to think about how the pathology of the epilepsy may be affecting brain networks outside the epileptogenic zone, which may be responsible for some of these comorbidities. And I suppose the eventual holy grail is, are there techniques we can use to modify the network which actually might affect some of these comorbidities as well as affecting seizures? And that's something which traditional epilepsy surgery in a way is quite poor at doing. We have very good rates of seizure freedom, but we do not have good rates of improving some of these comorbidities. There is a little bit of, that one's coming after. Oh, sorry, I've lost a slide. Apologies. There is a small amount of animal data which I thought I'd included here, but I haven't, which shows that we can, in rat models of epilepsy, affect cognitive skills during interictal periods with stimulation, and that post-ictal recovery can be influenced by deep brain stimulation. And this kind of talks to the fact that it's not necessarily just the seizures that are causing impact, but there are wider network disturbances which are maybe independent of the seizures, with seizures possibly being the common final pathway. And by understanding the effects on the networks of neuromodulatory treatment, we may therefore be able to tune our neuromodulatory therapies to optimize network normalization with a view to reducing comorbidity. We're in an interesting place with neuromodulation in that the field is expanding fast. This is a really nice recent paper written by one of my friends and one of your colleagues, George Ibrahim in Toronto, who was talking about the normalization of deviance and just calling out that we need caution when we are introducing new techniques, particularly when they're considered to be minimally invasive, because it's difficult for the data to sometimes catch up with the speed of innovation, and to make sure that we actually allow innovation to take place, but also ensure that we prioritize patient safety and maintain data collection in a way that we can optimize the decision making and treatment choice. So I would conclude to say that I think networks are a very useful model for epilepsy. The interesting change has been that we're now able to quantify networks. This has led to an increasing number of therapeutic options and candidacy, but we have a long way to go in terms of understanding the optimal techniques, both in terms of this network quantification. At the moment, we have many different techniques which are available and many different modalities that are available, but also in terms of therapy, in that we have multiple different therapies that are available and multiple different ways of delivering those therapies, whether it's in terms of modality of treatment, whether it's in terms of target for neuromodulation, whether it's in terms of frequency, pulse width, and some of the more technical aspects to neuromodulation. There is a very small amount of data that genuine network normalization or a movement towards normalization may be possible, and this is a really exciting area for further exploration in the future. I'm going to leave you with a picture of our team and some of our patients and some of our sponsors, and thank you very much for your attention.
Thank you so much for your excellent and clear talk, Dr. Tisdale. You've generated a lot of questions in the chat, so I'll start addressing them. So Oscar was asking, thanks for the presentation. Why do some patients with hypothalamic hamartoma have gelastic seizures and others don't?
So it's not something which anyone has a complete answer to, but I'll